Good morning, everyone. Cello, let's begin. Today, we are going to discuss one of the most important, most fundamental systems in all of human physiology. That is the renin-angiotensin system. For every medical student, this is a must-know concept, not just for your exams, but for your entire career. You will be dealing with this. So let me ask you a question. How does our body, control something so dynamic, so vital like blood pressure? It's changing all the time, right? So is there some kind of a master switch? Well, the answer is a very big yes, and that switch is called the renin-angiotensin system, or for short, we will call it RAS. So this is our plan for today's class. First, we will properly meet this RAS. Then we will meet its main actor, a very powerful molecule called angiotensin II. After that, we will see how we, as doctors, can interfere with this system. We'll focus on two superstar drug classes, the ACE inhibitors and the ARBs. And finally, the most practical question, how do you choose which drug to give?
All right, so let's get started. To understand the drugs for hypertension, for heart failure, for kidney disease, you first have to understand this beautiful logical system. Everything starts from here only.
The easiest way to think about this is like a factory assembly line, okay? So the liver makes a raw material called angiotensinogen. Now, when the blood pressure drops, the kidney releases a special enzyme called renin. This renin, it acts on the raw material and converts it into an inactive product, angiotensin I. And finally, another enzyme, angiotensin-converting enzyme, or ACE, this one converts angiotensin I into the final super powerful product, angiotensin II. And this fellow, angiotensin II, is the one who does all the main work.
So now our main actor is on the stage, angiotensin II. This whole system, this entire cascade, is designed just to make this one little peptide. And why? Because it has very powerful, widespread effects all over the body. And all these effects are designed to do only one thing, to raise your blood pressure. Let's see how it does it. First, angiotensin II travels the adrenal glands, those small glands sitting on top of your kidneys. There, it stimulates a specific part, the zona glomerulosa, to release another hormone, aldosterone. Now, aldosterone's job is to tell the kidneys, hey, hold on to sodium and throw out potassium. And you must remember this golden rule in physiology, where sodium goes, water follows. Simple. So more salt in water means more blood volume, which means higher blood pressure. But angiotensin II is very clever. It doesn't just rely on a messenger like aldosterone. No, it acts directly on the kidneys also. It increases the reabsorption of sodium in the very first part of the kidney's filter tubes, the proximal tubule. It also squeezes the kidney's blood vessels, which reduces the blood flow. Both of these actions make the body hold on to even more salt and water. You see the pattern now, right? And this shows you how smart the system is. Angiotensin II even goes to your brain. Can you believe it? It can make you feel thirsty, so you will drink more water. It stimulates the release of ADH, the antidiuretic hormone, which tells your kidneys to save even more water. And it increases the fight or flight signals coming from your brain. So it's attacking the problem from all sides to increase your plasma volume. And finally, in the rest of the body, angiotensin II boosts the sympathetic nervous system. It triggers the release of adrenaline, it stimulates nerve clusters, and it increases the output of norepinephrine from nerve endings. All of this leads to the tightening of blood vessels, what we call vasoconstriction, and an increased heart rate. The main point to remember is this. Angiotensin II is one of the most powerful vasoconstrictors our body makes. Okay, so now we understand the system. We know it's a powerful way to raise blood pressure. Now, as doctors, what if we have a patient whose blood pressure is too high? The most logical thing to do is to sabotage this system. And lucky for us, pharmacology has given us many clever ways to do exactly that. As you can see here, we can interfere at many points in this cascade. We can decrease renin release, we can block renin's action, or we can even block aldosterone at the very end. But our focus for today's class is on the two most common points of attack. Number 3, preventing the creation of angiotensin II with ACE inhibitors, and number 4, blocking its action with ARBs. Let's start with the first family, the angiotensin-converting enzyme inhibitors. A very, very important class of drugs. And a useful tip for your exams and your practice. Their names almost always end in pril. Ramipril, enalapril, lisinopril. Remember the prils. So what do? Are The definition is right there in the name itself. They inhibit the enzyme ACE. So by blocking this enzyme, you stop the conversion of the inactive angiotensin 1 into the powerful angiotensin 2. No angiotensin 2 means no vasoconstriction, no aldosterone, and so no rise in blood pressure. It's very elegant, no?
But here is the twist in the story. This is a very, very important point. This ACE enzyme, it's not completely specific. It has another job in the body, which is to break down a substance called bradykinin. So when you block ACE, you don't just reduce angiotensin 2, you also cause bradykinin to build up. Now, this bradykinin also causes vasodilation, which is good for lowering BP, but it is also the main culprit behind a very famous side effect. And that side effect is a persistent, dry, irritating cough. This happens in about 10 to 16% of patients, and it is caused directly by that bradykinin building up in the lungs. So you must remember this crucial link. ACE inhibitor leads to increased bradykinin, which can lead to that characteristic cough. Now, this problem of the cough made scientists think, what if we could block the system without touching bradykinin? And that thinking led to our second family of drugs, the angiotensin receptor blockers, or ARBs. And again, a helpful trick to remember them. Their names all end in sartan: losartan, telmisartan, valsartan.
The ARBs, they use a different strategy. They don't stop the production of angiotensin 2. No, the factory is still making it. Instead, they go to the places where angiotensin 2 is supposed to work. It's AT1 receptors on blood vessels and the adrenal gland, and they block those receptors. So angiotensin 2 is there, but it can't do its job. It's like you have a key, but someone has put glue in the keyhole. So let's compare them. The most crucial point is that ARBs do not interfere with the ACE enzyme, so they do not affect bradykinin levels. And what does this mean? No cough. This is their biggest advantage. They also provide a more complete blockade of angiotensin 2, because some angiotensin 2 can be made by other pathways that don't even use ACE. The ACE inhibitors would miss this, but ARBs block the final receptor, so they block all angiotensin 2, no matter how it was produced. So now we have two excellent classes of drugs that both target the same system. And this brings us to the practical clinical question. For your patient with hypertension, which one do you choose? An ACE inhibitor or an ARB? A pril or a sartan?
This table summarizes it all very nicely for you. See the mechanism: production block versus action block. See the bradykinin effect, increased versus no effect. And this directly leads to the key side effect difference, the cough. But look at the clinical uses. They are almost identical. Both are excellent for hypertension, congestive heart failure, after a heart attack, and for diabetic kidney disease. So, what is the key take-home message for you? Both are considered first-line drugs for high blood pressure. Because we have many, many years of data, ACE inhibitors are often still the first choice for conditions like heart failure and post-heart attack. However, if a patient develops that irritating cough, then an ARB is the perfect alternative. You simply switch them. Now, one final point, and this is a critical, non-negotiable safety warning. You must remember this for your entire career. Both of these drug classes are fetopathogenic. They can cause harm to the fetus, especially in the second and third trimesters. They absolutely must be stopped if a woman becomes pregnant. This is an absolute contraindication. Very, very important. And what does all this mean in actual practice? Well, this chart shows the trend. Because ARBs are much better tolerated, mainly no cough, they have now become more popular than ACE inhibitors for starting new patients on therapy. Doctors and patients both prefer a drug with fewer side effects, and so the sartans are now prescribed more often than the prils as a first choice. We will end with a question for you to think about. We know these drugs lower blood pressure, but for a patient with diabetes who has early signs of kidney damage, but their blood pressure is normal, we still prescribe these drugs. Why? Think about what angiotensin 2 does directly to the kidney. This concept of organ protection is a very crucial one to understand. Okay? Thank you for your attention.
Hello, everyone, and welcome back. Today, we're going to tackle two topics that are, believe me, absolute must-knows for your cardio exams. We're talking about the RAS pathway and nitric oxide. And this isn't just theory for your papers, okay? You will see these concepts in your clinical practice every single day. So you need to pay close attention. Let's get right into it. So, we've all studied the RAS pathway, right? And when you first learn it, the logic seems so simple, so straightforward. If blocking the pathway at one point is good, surely blocking it at 2 points must be even better. It just makes sense. But as you are quickly learning, pharmacology is not always so simple. The body has its own ways of responding, and sometimes, well, it can be quite surprising. And this is exactly where that simple theory met a very, very different reality. Just look at the data from huge clinical trials like the On-Target study. The results were, and this is a key term you must remember, discordant. What does that mean? It means the combination therapy just didn't consistently show better outcomes. In fact, a lot of the time, monotherapy was just as good, if not better, and it came with fewer side effects. This really made the entire medical community sit up and rethink their whole approach. Okay, so if blocking the pathway later on has its limitations, what's the next logical step? Well, the brilliant idea was, why not go right to the source, to the very beginning of the whole cascade? And this line of thinking led to the development of a completely new class of drugs. This class is called the direct renin inhibitors, or DRIs, and the main drug you need to know in this category is aliskiren. Now, it's a non-peptide drug, which really just means it's a small molecule, not a big protein. And its genius is that it directly targets the one enzyme that starts this entire process, renin itself. Now, the way aliskiren works is actually quite clever. The funda is very simple if you just think of it like this. The entire renin-angiotensin system is like a factory production line, okay? And its sole purpose is to make angiotensin 2. And renin? Renin is the factory manager who shouts the first order to get the whole production started. So what does aliskiren do? It goes straight to the manager, to renin, and it binds right to its catalytic site. It's almost like locking the manager in his office. This competitively blocks the raw material, angiotensinogen, from even getting access to the enzyme. So you see, if the raw material can't meet the manager, no angiotensin 1 is produced, and the whole production line is shut down before it even begins. It's simple, and it's very, very effective.
So what are the key clinical points you need to remember for your exams and, of course, for your practice? Well, aliskiren's blood pressure lowering effect is good. It's quite similar to an ACE inhibitor or an ARB. You might see side effects like hyperkalemia, but notice, the cough and angioedema are less common, but its current place is as an alternative drug. And here are two very important warnings, absolute red flags you must not forget. It is not recommended in combination with an ACE inhibitor or an ARB in type 2 diabetics, and it is absolutely contraindicated during pregnancy. You have to remember these points.
All right, so we've just talked about a complex drug molecule, something that was meticulously designed in a lab. Now, we're going to shift gears completely. We are moving from a complex, man-made drug to something incredibly simple, yet profoundly powerful, that our very own body makes. Yes, you heard that right. We are going to talk about a gas, a tiny, simple molecule with the formula NO. This gas acts as one of the most critical signaling molecules in our entire cardiovascular system. Honestly, it's a true game changer. We are talking about nitric oxide, or NO. You know, for years, scientists knew there was some kind of substance released by the blood vessel lining that caused it to relax. They even gave it a name, endothelium-derived relaxing factor, or EDRF. The discovery that this EDRF was actually this simple gas, well, that was a revolutionary Nobel Prize-winning achievement that completely changed how we understand cardiovascular physiology. And this slide, it just beautifully illustrates the whole journey of scientific discovery. It's like a fantastic detective story. First, Murad finds the initial clue. Drugs like nitroglycerin work by releasing NO. Then, Furchgott and Zawodzki discover this mysterious character, this EDRF. And finally, Ignara was the one who connected all the dots and proved that EDRF and NO were the exact same thing. It's a fantastic story of how science really works, with different pieces of the puzzle just coming together over time. So, how is this magical gas made inside our own bodies? You have to pay close attention to this pathway on the slide. It's very, very important. It's synthesized from a very common amino acid, L-arginine, and the enzyme that performs this magic trick is called nitric oxide synthase, or NOS. So it's that simple. L-arginine goes in, and nitric oxide comes out. But the real magic, the truly amazing part, is how this gas, which, mind you, only exists in the body for a mere 4 to 10 seconds before it disappears, can have such a powerful and immediate effect on our blood vessels. It is absolutely incredible when you really stop to think about it. Look closely at this diagram with me.
Once NO is produced in the endothelial cell, that's the inner lining of the blood vessel, it doesn't need a receptor or a transporter. Why? Because it's a gas. It simply diffuses straight across to the nearby smooth muscle cell, and there, its main target is an enzyme called soluble guanylyl cyclase, or SGC.
Now, if that diagram seems a little too complex for an exam, don't worry. Just burn these 4 key steps into your memory. It is a simple, beautiful cascade. 1. NO activates SGC. 2. SGC makes CGMP. 3. CGMP causes the dephosphorylation of myosin light chains, which is what stops muscle contraction. And 4. The result is muscle relaxation and vasodilation. Just remember this simple funda. NO leads to CGMP, and CGMP leads to relaxation.
But please, whatever you do, do not make the mistake of thinking that NO is just a simple vasodilator. Its function extends far, far beyond just blood vessels, making it a true jack-of-all-trades molecule in our body. Its importance is really staggering. It's an antiplatelet agent, helping to prevent blood clots. It's a weapon our own immune cells use to kill bacteria. It's a neurotransmitter in the brain, essential for things like learning and memory. It helps regulate blood pressure in the lungs. And yes, it is the key molecule that mediates penile erection. This incredible versatility is what makes nitric oxide so absolutely fundamental to our physiology.
So what's the key takeaway from our session today? It's that pharmacology is a field that is always evolving, always pushing forward. We've seen a complex, rationally designed drug like aliskiren, and we've also come to understand the profound effects of a simple, naturally occurring gas like nitric oxide. From complex chemistry to simple biology, we are constantly discovering new targets and new ways to treat diseases. So I want you to keep thinking, keep questioning everything, and I will see you in the next class.